Here we go. What's up, everyone? Welcome to Pardon the Resuscitation, the post-show rundown. Let me get one person on here. Taryn is supposed to be here. He's stuck in traffic, so pinch hitting. My man, Colin McCluskey. What's up, my man?
It's good to see everybody. Thanks for having me.
We should actually go around the horn and just introduce everybody because, you all are familiar faces, but just to be sure, why don't we start off with Colin?
Hey folks, I'm an EM intensivist out of Cleveland, Ohio. I do a lot of CT/ICU as well as resuscitation at a level 1 trauma center, and so I'm happy to share what I've learned.
Cool. Steve, why don't you go next?
Hey guys, I'm Steve Haywood. I'm a former respiratory therapist and an emergency medicine physician in rural Mississippi. I have a passion for rural resuscitation, doing resuscitation when you don't have all the resources of your big level 1 center. And you can check me out on social media at HeySteveMD.
All right, Sham.
Speaking of rural, I got the opposite. I'm at the big academic at University of Pennsylvania, finishing up my surgical critical care. I've got 3 weeks left and off to my first job. I'm excited to be here.
And then Chris.
Hey everyone, I'm Chris Riley. I'm actually an EM attending at Maimonides Medical Center in Brooklyn. I'm also pursuing a master's in medical education. That's my passion. That's why I'm here. So I'm excited to be here and looking forward to the discussions.
Fantastic. All right, well, let's get right to it. Colin just finished his shift, and so we want to ask him a couple questions about his talk and his rundown. Who wants to kick it off?
So Colin, I'll start. I loved your lectures. So your lecture, you talked about what doesn't work, what meds we shouldn't be doing, all the things that we shouldn't be doing in cardiac arrest. If you could kind of summarize for us, what would you say are the top 2 or 3 things that you most commonly see people doing there in a resuscitation that they should stop doing?
Well, I think complexity is the enemy whenever you're doing resuscitations and running teams. And so if you can take away things that aren't adding a ton of benefit and focus on things that actually do, that entire scenario is going to go better for both your team and then your personal cognitive performance. So I see a lot of people worrying about what meds to do. And a lot of this is prompted by the other resuscitationists on the team of, hey, do you want to give this X or Y? In a true cardiac arrest, it's really the quality of compressions, early defibrillation, and we can talk about how you do that correctly now that we have dose VF. And then if you're at a big center like mine or a center like Cheyenne that has maybe eCPR capabilities, those are the ones that actually move the needle for neuro intact survival. Almost everything else doesn't. So unless you're running your team well to make sure those compressions are tight, that you're defibrillating in a way that's delivering a lot of electricity in the right way and mobilizing all your resources, you're probably spending a lot of mental energy in places that aren't going to get most bang for that buck.
I think that's the gospel of the resuscitationist of CPR. Chest compressions, early defibrillation. Don't worry about anything else. Chest compressions, early defibrillation. At what point are you thinking beyond that? At what point are you saying, okay, I've shocked 2 times, I've shocked 3 times. At this point, I need to start thinking about something else.
Well, I think if you've done, if you've read dose VF, you've done dual sequential stuff, you've changed your pad placement, you've shocked, and you still have VT, VF, a shockable rhythm. At my shop, we're putting you on ECMO. That's an easy day. You're now refractory VF VT. Now, in rural Mississippi, that might not be the right move, right? So I think, this plays into what resources you have, right? Now, at that point, is it cool to go with amio, lido? I didn't have it in my talk, but pushes of esmolol, sure. At this point, as long as you've concentrated, you've done your due diligence to maximize the things we know work, then yes. Start upping the complexity because you've already maximized the things that have the most bang. I think that's perfectly fine. But worrying about, what your esmolol load is at minute 1 of your resus is probably a mistake.
Yeah, I agree. I love that you brought up pill sequential. I know historically, I think it's been after 3 shocks you grab it. I think the most recent paper said after 2 shocks you grab your second defibrillator. When are you going for that second defibrillator, throwing that second set of pads on, Colin?
So when our folks come in, they already have usually a set of pads on them from our EMS folks. we're putting on the pad positioning that they don't have as part of when they're moving over from the gurney. So if they're AP, if they're anterior lateral, we're putting on AP, and then our next one is either going to be the shock try that they didn't have position, and then we have dual sequential. That limits our any time of poor compression, and then we're already in a good situation. But I got a lot of hands at my center. That might not be the easy thing for you in rural Mississippi.
I like it. Sean, Chris, any questions?
I was just going to bring up that I want to throw it to you, Steve, and ask about like what's your protocol when you've only got 4 pairs of hands? What are you doing?
One second before you jump in there. Let me get the latecomer here. Let me get the lazy guy. The bum.
Oh no, here he comes.
Man bun time.
Oh man,
He's not
Sorry
even
about
there.
Oh my gosh. My gosh.
I just
Is
wanted you all
that him?
to appreciate my gardening skills.
That's pretty
gorgeous.
good.
It's gorgeous. Yeah.
Here he comes.
God.
My man can save a life and prune a bush.
There he is.
Very zen, very zen.
Man, that is beautiful.
It's my pride and joy. I literally invite people over here and I just wait for them to like say something. I'm like, you're gonna compliment this, right? Get out of here.
Gorgeous.
All right,
Gorgeous.
Steve, go ahead and answer your question.
Yeah, so we're talking about dual sequential. I love what Colin said because especially if I'm working at one of the freestandings that's like really out there where I have 2 nurses and 1 paramedic in my shop, I utilize EMS's stuff. Their machine stays on the patient and we add our pads on top of that, or not on top of it, but and for that second vector, the other thing I do is I make them stay. Whichever crew brings them in, I'm like, please stay and help us out. I can desperately use 2 extra sets of hands, 2 fresh backs to help us with chest compressions, to take rotations. So yeah, doing pretty much what Colin does, keeping those pre-hospital pads on and then putting my pads in that second vector and start with shock in mind. And then honestly, after 2, that recent paper in New England Journal that summarized it, after 2 unsuccessful single shocks, I'm getting that second defibrillator on and using them both.
Now, do you do vector change single shock first, like single machine first, and then do the dual sequential on your next shock? Or are you going straight to the dual sequential?
If EMS has AP pad placement, I'm going to put my pads kind of here and here, so I've got a new vector. It's essentially a vector change, and I may do 1 shock with just mine, and then if that doesn't work, then I'll go, shock 1, shock 2 on the next pulse check after that.
Awesome. Yeah.
Is that what you're doing, Colin? Am I quoting you correctly?
Yeah, usually people are coming into the universal position of critical illness, which is flat on their back. So they have usually an AL, and we know from some of the AFib cardioversion literature that like the AP is probably better. So that second vector change is probably the right move. But yeah, I'm going to give it 1 shot there. Now I'm not waiting, between pulse checks. We know time of VT, the longer you're in VT, the longer you're in VT, or the more soon you're going to be in asystole. So I'm going to try those pretty rapidly while we're doing, compressions, the 1 vector change, it doesn't work, compressions, ready for dual sequential, yup, let's go.
And Mississippi, we are number 1 in obesity rates. So my patients that are just huge, you've got 1 small vector, I don't know that that's hitting the heart at all. And if it is, I don't know that it's depolarizing 85% of it. So by putting those second sets of pads on, doing that dual sequential, I'm more likely to depolarize 85% of the myocardium, which I know I need to kind of reset everything. So a bunch of questions in the chat. The first one's mobile apps for out-of-hospital cardiac arrest. Some of my residents use these. I don't use these. Anybody else on the panel using any apps to run your codes with?
So I think one of the most important things to do, because we always forget about this, is some sort of metronome to keep the beat, right? So everybody does, it's staying alive, but having that loud, annoying metronome can actually be super, super helpful in cardiac arrest. The one I have is actually just called Pulse, and it's super simple app. You set the pulse rate, this is set to 110 beats per minute, and that's it. That's awesome. The entire time. So something like that, super simple, but could definitely make a huge impact.
I know there's some others
think
that
it
kind
can
of
be a
claim they do
little.
pulse checks.
I think it can be a little weird to play music during a code.
Yeah, that'd be weird.
I sing
The
Baby
Bee
Shark.
Gees.
That's my go-to, and I get right on their hands and I sing it with them because people go too fast. I've counted before, and they're compressing at like 150 beats a minute. You know what I mean? And so usually I'm slowing them down, and Baby Shark is my go-to. That's kind of what I was doing there.
Fun fact: Turn Down for What is also 100 beats a minute. Just throwing that out there.
Yeah, Baby Shark's going to be my go-to because it's impossible now to forget it out of my head. So thank you, Steve. I appreciate it.
Oh my God, is it
brutal?
If it wasn't stuck in your head, it will be. Yeah. A question about nurse-led codes as well here in the chat. So we're not doing nurse-led codes specifically, but I utilize my recorder and I cognitively offload a ton of stuff to my recorder. I tell my recorder, hey, and my recorder, as I offload things, my recorder essentially is leading the code. And then if I am in a solo shop, I don't try to do two things at once. So if I've had multiple IOs that fail and I need a crash line, I very rarely do it. But if I've got to do that, then I say, okay, Michelle's going to take over as team leader, as the recorder, while I do this. I'm micro-focused on my one task. And then as soon as I'm done with that, if I'm stepping back into the role of team leader, I kind of announce myself as team leader. But I don't do a specific nurse-led code, but I do offload a ton to my recorder. At your bigger shop, guys, what else are y'all doing?
Yeah, frankly, I think that's the way of the future, nurse-led codes. I think that's really where we need to be headed. I would say at my shop, we have so many people around that usually a doc or an APP is running the code. If I'm in the room as the fellow with an APP, I usually let them run the code. That frees me up to do procedures, do POCUS, those kind of like other ancillary things. But I honestly think the nurses should be taking over that because it's certainly within their scope and they do a great job of it, frankly.
So Colin, let me just kind of kick it back to you and let's ask you a couple more things about your talks because I want to turn this into a summary session. From your talk today, calcium, it sounds like you're pretty anti-calcium, but let's say you're sort of in the pits of the code is running down, it's gone like 45 minutes and someone really, really wants to push calcium. Are you going to be that kitchen sink at that point or what? I mean, I guess it goes for any of the drugs, right?
Hey, I think like 45 minutes in, if you think calcium is going to carry the day, you haven't done this very long. But like, sure, right? Like at that point, if we're kitchen sink and really, I'm not doing it because I actually think we're going to get ROSC or I actually think it's patient, but I want to actually encourage the kind of the shared mental model of the room. And if I have like either a junior learner or someone else in my team who's like, hey, this is a suggestion I want to try, and there's nothing against it, it's not making things overly complex, hell yeah, we'll do it. Yeah, that's a great idea. Thanks, we're going to try it. Hey, who knows? Like my crystal ball is really cloudy on how the next 15 minutes of this code is going to go. Why not? But I know from the data that I don't expect it to have a large effect on patient-centered outcomes.
Colin, I wanted to ask you because we talked a lot about different medications. And how do you feel about bicarb in like the metabolic phase of arrest, a delayed or later in arrest? Do you have a stronger inclination towards using bicarb down the road, or are you going to say no, bicarb is just not part of it?
So the best data for using bicarb in any critically ill patient outside of kind of the antidotal therapy that we kind of talked about with like sodium channel blockade is really in folks that are like have renal dysfunction that you're going to make a decision on saving them from the green machine, renal replacement therapy or not. That's what bicarb ICU says. I think in the context of cardiac arrest, you got to get the reason that they arrested better. And the answer of that is not like bicarbopenia. That's not what led to all of this. So if you're in the metabolic phase, this is the area if you think, is this a human that could be supported with mechanical support? Because later on, it's like bicarb is not going to make anything better for you if it's not antidotal therapy. And we know this from almost every paper that's looked at bicarb use in any phase of cardiac arrest.
Let me have one more follow-up question. I want to steal you for a second. Do you think there's anything that we haven't studied enough? Is there something out there that you would like to see more data on? I don't know, magnesium. I don't know. So, whatever. Is there anything that comes to mind with that prompt?
It's interesting. I think there's still more work to be done. As much as like we have eCPR at our shop, we know we have the arrest trial. We need to see to figure out who are the best candidates and what is the best mode of system delivery for eCPR for these out of hospital cardiac arrest folks. I think that's where we're going to move the needle. And what does that delivery system look? Is it a pre-hospital deployment? How are we using that? What are the assets that we're going to bring? I think it's that kind of system level research and away from, there's no silver bullet in cardiac arrest. I wish there was, like, you know what it is? It's exercise and not smoking. That's the silver bullet for cardiac arrest, but like the ship has sailed there. So like, how are we going to resuscitate these folks? It's probably with some form of cardiac bypass mechanical support. And it's how do we systematize that in a way that's scalable?
That's awesome. That's a great answer. Hey, go ahead, Chris.
I was going to say, I think you forgot one part of that silver bullet. I think it's living in Mississippi too, right? That's what we were talking about?
He said exercise.
Oh, gotcha. Sorry. I thought I missed that.
Well, Colin, we won't take up any more of your time. Thank you so much for joining us and letting us ask you some questions on your lectures and stuff like that. Really awesome. Thank you so much.
All right. Yeah, and bystander CPR, early defib. Anyone who's watching out there, you see somebody go down, get on their chest. That's huge.
Amen. Preach.
Words of wisdom. So, our first block of lectures were a lot of pre-hospital EMS topics along those lines. What were some of your all's takeaway points from, the first couple of lectures where we were talking about pre-hospital supraglottic devices, things along those lines, racial disparity. We talked about mechanical CPR. What were some of your all's takeaways from those early lectures this morning?
Man, I loved everyone's lectures today, and I love they started off kind of with the pre-hospital of do what you know to do, high quality early chest compressions, early defibrillation. And especially when they're talking about the mechanical CPR devices, I really expected them to be all about them. But I love that everybody said, that's not my first priority. That's not my first priority. My first priority is effective chest compressions, recognition of rhythm, and early defibrillation. And really, your thumpers, your squeezers, getting those on is going to take away time that you could spend getting pads on, getting your monitor turned on, delivering that shock. I felt that was the theme of the day, but really these pre-hospital providers that we're talking about, I'm going to do what I can do on scene. I'm not just going to burn diesel and run them to the ER. I'm not going to fool around initially with getting this thumper on. I'm not going to mess around with the airway. I'm not going to get IVs, effective chest compressions, early defibrillation. What are your thoughts, Sean, Chris?
I was just going to say real quick, I thought Simon Taxel made a great point about sometimes we don't have the resources, sometimes we don't have the people around to deal with that, which is why they go to that mechanical CPR, right? So that's not their go-to, right? And then Lindsay Ewing talked about stay on scene. That's work them on scene has better outcomes than just the grab and go. So it's all dependent on your resources and how many crew members you have with you with those cardiac arrest situations. In terms of the EGA, I mean, definitive versus temporary airways, we've kind of switched from the ABCs now to CAB, right? So I feel like if, again, you're limited resources, limited people around, supraglottic airway, you just got it. So.
Yeah, and that kind of links forward to Tarlan Hidayety's lecture later in the day where she talks about airways and cardiac arrest. And I think the take home there is really, you can use either endotracheal or supraglottic if you have to go to those advanced airways. From my own kind of dive into the literature, it seems like basic airway maneuvers, BVM, OPA, NPA, those are really good enough for the acute resuscitation phase when you're in the cardiac arrest. But if for some reason you need an advanced airway, either one is probably appropriate for your patient.
And one more quick point. one more quick point on just pre-hospital in general. A good point was that, just have some perspective for these guys. They're out there in the field, and that's tough. Minimal resources, minimal people around. So just keep that perspective in mind. Just wanted to give that little hot take for my EMS people out there.
Well, additionally, we need to be invested in our pre-hospital personnel. I loved hearing everything that Lindsay said that she's capable of doing and she's trained to do, and her units are trained to do. They had a lot of investment and buy-in from resuscitationists who trained them, made sure they had training programs, and doing a lot of good, saving a lot of lives. So invest in your EMS personnel. Don't just tell them, load them and burn diesel. Teach them how to work them on scene. Teach them how to do the high-yield things that we know make a difference. And we'll see returns and save lives.
Yeah, 100%.
And then the rest of the morning, we kind of moved into a couple other intra-arrest topics, right? We had Tarlin talking a lot about PEA and hitting a lot of different aspects on that. Haney talked about ultrasound in the code. Jeremy Pallas talked about, nurse-led resuscitation. What did you all take away from that block and those lectures?
Yeah, I really liked that section because it was a little bit of I guess, adjuncts to ACLS, if you want to call it that. Like we have adjuncts to our ATLS. But I really enjoyed this section because it focused a lot on ultrasound and, how can you cognitively offload to the nurse and allow you to focus on other things that can help diagnose and treat the reversible causes, which is right up, right up the alley of Hidayety's lecture on PEA algorithms. What do you guys think?
Yeah, I love Tarlin's and I love Haney's as well, talking about the ultrasound because they kept it realistic and practical. I think, 5 years ago, 10 years ago, what I was seeing was people obsessed with ultrasound and spending a ton of time on the chest and repeating a subcostal view at every pulse check. And I think it was Haney that said, if you didn't have tamponade the first time you checked, you probably don't have it the fourth time you checked. So doing those quickly, but not letting them interfere with the most important things of chest compressions. Look for your reversible causes, and then maybe use it on a vessel to look for a pulse. So again, love the perspective and love the balance. I love ultrasound. I love ultrasound in a code, but you got to have balance.
Yeah. Just to review for the viewers who weren't here with us earlier, the CASA exam is what actually Haney recommended doing, and that's for 3 consecutive pauses, you put the ultrasound probe on the chest. The first time you look for just tamponade. If you see a tamponade, you fix it. If you don't, probe is off and you continue compressions. The second time you look for right heart strain. And then the third time you're looking for motion, cardiac motion. And particularly in that order, because it allows you to fix the reversible cause really quickly, look for another reversible cause. And then the third one is really kind of more of a prognostication and trying to help you decide how long do you keep going.
Yeah, I was going to say with ultrasound in general, there's a lot of different protocols out there. The CASA is simple, it's straightforward, and it gives you, again, some cognitive offloading. You just have this algorithm in your head. You're doing the same thing every time. So that's super important. Something I started actually to do in residency was actually using color flow Doppler for the linear probe when doing pulse check during cardiac arrest. I know there's been some newer literature out there showing the linear probe use during cardiac arrest and actually looking at mechanical CPR with the pulse wave Doppler, right? And actually seeing those waveforms in conjunction with mechanical capture of the heart. So there's a lot of great research out there, and just ultrasound is continuing to show us that there is so much we can utilize from it.
So speaking of, actually, I'm going to throw it back to Taryn to summarize your talk about using pulse wave Doppler.
Yeah, I'm super stoked about that topic. So, Chris, thanks for kind of segueing into that. You throw a pulse wave Doppler on a femoral artery and you have a velocity of 20 centimeters per second or more, that correlates very well with a systolic blood pressure of 60 or greater. And that was one of my main take-home points from my lecture, the subsequent block. So, Chris, you set me up perfect. Thank you.
Sorry to steal your thunder.
That's always the question
That's
too,
right.
because you get that subcostal view and you see a little quiver and the valves are opening and closing. And you're like, does this equate to a pulse? Does it not? So, man, throw the pulse wave on there, measure it. I love it.
Yeah.
Yeah, I like that concept a lot. Now, Tarlin did end up talking a lot about airway in arrest and basically went through all of our different head-to-heads, supraglottic devices versus endotracheal tube, BVM versus endotracheal tube. And one of the things I really liked about her highlights on when she was talking about BVM is that it really does take a skilled operator to do high-quality BVM. And she mentioned it a couple times that, if you have different soiling of the airway or if it's a mess, you're probably going to have lower success rates with BVM. And her lecture as a whole highlighted a bunch of pearls and takeaways from when you would select one patient versus the other for a supraglottic device or endotracheal tube or BVM. What else did you all get from Tarlin's lectures?
Yeah, I love it.
Again. Oh, go ahead, Steve.
You're highlighted, Chris. Go for it.
Oh, yeah. So, again, just highlighting this new mantra change from the ABCs now to the CABs, right? And with these airways, there's a lot of studies coming out. The meta-analysis she talks about where the EGA versus endotracheal tube intubation, no statistical significance, survival to admission, survival to discharge, neurological outcomes. There's a lot to unpack in her lecture, but I thought it was extremely useful hearing these points.
Yeah, she did a phenomenal job of working through some dense data in a very tangible way. So I really enjoyed her lectures.
Yeah,
Steve,
for
it
sure.
sounded like you had something to add.
What was that, Sean?
I was saying it sounded like you had something else to add. I also want to hear from your experience being a respiratory therapist and stuff, what the optimal technique for bagging is.
The optimal technique is two people, and I think we've all been there. We can all do a single person BVM breaths, but you get distracted when you're up there, especially with so many other things that are going on. So having one person that's just focused on holding the mask, doing the clamshell or the VE hold, just making sure you're opening the airway and holding the mask down. And then the second person, their only job is to make sure they don't overventilate the patient. Because we see that all the time, right? Where, the 30-2 goes out the window, we end up with continuous chest compressions and somebody just goes to town on the bag. So the optimal is a two-person technique. And if you've got to do if you've got to do a single person technique, I have a lot of skill variability on who can bag properly with one person. So that's when I'm dropping an SGA. I'm just dropping an SGA. I can do it quickly. I like the iGels. It has an esophageal port. And one person can easily operate an airway with SGA in place.
I think my only addition to that is the oropharyngeal and the nasopharyngeal airways always get forgotten in the heat of the moment when you're starting to bag. When you drop those in, the resistance goes dramatically down. You get all that tissue out of the way, clear a good path for the air to get down to the trachea. So I always recommend that we use those.
Same.
And our last couple of lectures, we had Scott Weingart talking about how we can master an A-line and master your monitors during cardiac arrest. McCluskey finished up with a bunch of interpretation of our current literature in medications in arrest. Then we also had Corey Slovis, the infamous Corey Slovis, giving a pretty convincing lecture on epinephrine in arrest. And I wrapped up with a little bit of steroids. What were some of y'all's take home from these lectures?
So I loved, Scott, smart guy. I love the thought of getting your A-line in as quickly as possible. When you're resource limited, sometimes that's after ROSC. But if you can get it in intra-arrest, Scott went through some of the fine details about how that can guide your resuscitation besides just pulse or no pulse. But getting that A-line in is so valuable, so valuable. So it's something I'm trying to do more.
Yeah,
so I thought
absolutely.
Go ahead.
Go ahead, Chris. I was just going to say the. All right, it's you.
No,
you go for it.
You got it. It's you.
Someone talk.
Haney.
All right, I'm jumping in. So I think the other interesting thing that I took away from Scott's lecture was about end-tidal CO2 and actually being able to use that waveform to kind of drill down and get a better sense of your patient's physiology. I found that really interesting. I think it's hard to explain it without the actual images. So definitely, whoever's had a chance to watch the lecture earlier today, you'll get access later, so you'll have to go back and watch it.
For sure. And then Taryn, so what's your practice? Are you giving steroids routinely? When are you making the decision to give steroids?
Yeah, so I went over some of the data, and the data is kind of parallel to what we have with epinephrine in arrest. I think it's reasonable that you're going to increase your likelihood that you have return of spontaneous circulation, but steroids don't seem to be improving neurologic survival despite a couple of theoretical mechanisms that would play out. And so I'll tell you right now that my practice is to not use steroids, and I think I wouldn't really criticize someone who did with their current, with current literature. AHA even says it's reasonable. My practice is that I don't use steroids.
I'm glad you're not, because I'm not doing it. And if everybody else is like, "Oh yeah, I'm giving steroids," I was going to feel like the dummy on the panel. So I'm not doing that either. If I need to start doing it, please shoot me a text and be like, "Hey Steve, start giving steroids in cardiac arrest." So, Sean, Chris, are either of y'all doing steroids?
No, and I think I have a little bit of an interesting perspective because I haven't been in the emergency department in a while. Most of my cardiac arrests end up being in hospital arrests, seeing that I'm mostly in the ICU nowadays for the last 2 years. So, frankly, a lot of those patients end up being on steroids to begin with, and adding more to it probably won't do much. So that's my take on it.
And then Slovis gave some, just dropped fact bombs on epinephrine. It's very
The
convincing
guy's a
that
beast.
epinephrine in the first couple of defibrillations was associated with worse outcomes, and that was like a very hard point for him.
Yeah.
Yeah, take it away, Chris.
Yeah, I was just gonna say, with his lecture in general, so many awesome pearls in there, so many awesome breakdowns of different studies. But a huge point he made is, what is your end goal here, right? These people, you're going to have a quarter more neurologically devastated patients alive at 6 months with epi. So it's like, do you ask the question, maybe less is more in that situation? What is your end goal? Is your end goal just to get ROSC and not think about, is this guy ever or girl ever going to walk out of the hospital again? I mean, I think that's definitely a huge point to think about. I mean, he said, if he's 25, 30 minutes into a resuscitation, you've already given 3 rounds of epi. He's like, all right, what are we doing here, guys?
And I know we're repetitive. We keep saying the same thing over because it's so true. Your priorities are not epi. Your priorities are not calcium. Your priority is getting on the chest, high quality chest compressions, early defibrillation. I feel like some old school, not even old school providers, just some people that get in habits and do pattern recognition. We see so much PEA pre-hospital that they're just so used to immediately slamming epi as the first thing, that when you have a shockable rhythm, you almost have to tackle people to get them to stop giving the epi. You're like, hey, let's give electricity a chance before we start pounding the epi in there.
Yeah, as I was watching Dr. Slovis's talk, I was just thinking back to the last code that I was part of, and at least the last shockable rhythm code, we definitely gave epi too early. So definitely something I'm going to have to take back and keep in mind.
Yeah, you almost have to lay over the IV site to stop them. They're ready. They're ready.
Yeah, and that point right there is huge. I mean, he talked about even waiting 2 to 3 shocks before considering epinephrine. So awesome lecture by Dr. Slovis.
And that's ACLS. We're talking about a lot of stuff that's beyond ACLS, but ACLS clearly says at least 2 shocks. And I like that Slovis says 3, and I'm kind of the same way. Sometimes I wait 3 or 4 and try a lot of other things before I go to epi.
Dude, that was a great summary of the day. I mean, there's so many packed pearls throughout the entire day and so many awesome lectures. I'm already looking forward to rewatching some of them. You want to take a couple questions from the chat, and then I think we should probably wrap it up.
Yeah. So I think we got down to Farhan asked, are we considering TPA, especially in a smaller hospital where you're concerned about PE or STEMI, refractory shockable rhythms? I have done this. I had a case at a freestanding ER where I had no resources. I had 2 nurses and a paramedic and my transport guys that brought the patient to us. But in this patient, I kept getting ROSC and then kept losing ROSC, and they kept going back into VFib, VTAC, and we'd get ready to transfer and we would go back into VFib. And at this point, I'm assuming this is STEMI. The RV wasn't super dilated, so I did give thrombolytics at that point. My post-ROSC EKG was equivocal. If I've been working somebody for 45 minutes and I still don't have ROSC, I'm not giving thrombolytics to that person, because again, once I give the thrombolytics, I really need to be working them for another 15 or 20 minutes to give those thrombolytics time to work. And I think the possibility of neurologic outcome has really probably been decided at that point. Y'all's thoughts?
Yeah, there are so many awesome exploratory concepts for refractory ventricular dysrhythmias and arrest. And I know tomorrow we have Dan Patino having a 2-part talk on VT Storm. So I bet he ends up kind of going into some of these. And I bet tomorrow's rundown, we're going to be breaking down a lot of that stuff too. That's right.
Yeah. I think I want to highlight something that Tarlin mentioned earlier about TPA for PE. And I think history is really important there, right? Mm-hmm. Their comorbid conditions, what they're presenting signs and symptoms were before the arrest, and then definitely looking at your ultrasound to see if you've got signs of right heart strain or there's a multitude of things you can look for when it comes to PE.
Yeah,
Joseph,
one of the questions.
I was just going to say we're not just doing a Hail Mary here. We're not just like, hey, just TPA. This is clinical context. I think that's super important here.
One of the questions, and I actually had the same question in mind, and I wanted to hopefully, tease it out when one of our panels, but it didn't happen. And do you think that epinephrine and maybe some other dose than 1 milligram might be reasonable? Is this something that you all have included in your practice?
I have hung some dirty epi drips after ROSC, while I'm waiting to get the levofed. And then, especially if the patient keeps arresting, I just leave that epi infusion going and I don't push epi anymore. And a dirty epi drip is probably 30 to 50 mics per minute. And if that doesn't get them back, then I don't think they're savable. My initial resus, if I'm giving epi, I'm still doing the milligram boluses. But if I have an epi infusion or really even a levo, norepinephrine infusion, a lot of times I'm leaving that going and then not doing big slugs of epi.
Yeah, it makes a lot of sense. And we heard a lot today about drips, epi drips, either in the background or as a post-resuscitation care.
Joseph's got another question. I was going to get another question from the chat. Bicarb or calcium after 30 minutes. I had a trainee that used to do this stuff where this patient had been down forever. And they're like, before I call it, I'm going to push calcium, I'm going to push bicarb, I'm going to push magnesium, and I'm going to push 2 milligrams of epi and just make sure they're not savable before I call it. And we admitted a lot of corpses to the ICU with that cocktail. So I'll echo Slovis. If you've got a clear indication for calcium and bicarb, such as hyper K or a TCA overdose, give calcium or bicarb. Other than that, I'm going to look for other reversible causes. I'm going to do high quality CPR. And unless I have a clear indication to give those meds specifically, I'm not going to give them.
Yeah. If you see wide QRS, on the monitor, and you're concerned with sodium channel, toxicity, that kind of stuff, absolutely. But again, clinical context, right? We're doctors, right? Got to think about it.
Well, I think we're going to wrap it up there. I know there's a lot of other great comments in the comment section. Hopefully we can get to... Yes, okay.
I got one last thing.
All right, and, one more.
One last thing, and I'm sorry, Steve, to disappoint you. This is coming from the comments. Didi Delalic commented, there was a study comparing resus stimulation done without music versus done with Baby Shark playing in the background. Now, I had to look it up. because I really needed to know the results of this. So
Let's
I
hear
looked it up. 58 participants randomly assigned to listen to a minute of Baby Shark or Whale Song. Not sure exactly what that is. And then do a minute of CPR. They found there was no difference in the groups. Both did compressions greater than 120. It was 121 versus 125. And Baby Shark group, though, did have more compressions completed in the target zone of 55. 55% were done in the target zone, which is 115. No, I don't know what that is exactly, but we'll have to dig further into the paper. But sorry, I got to say Baby Shark may not work for you.
Get out of here with that. I'm still doing it. I'm still doing it.
Did they talk about acute psychosis rates after?
Yeah.
My God.
Trauma. We got to talk about the emotional trauma.
Oh, too much.
All right, that's awesome. Thank you for ending us on that note. That is perfect. All right, well, tomorrow's day 2. We'll be back for another rundown tomorrow evening. Thank you all for joining us.
It was fun. Thanks, guys.